Good afternoon. Before we introduce our topic, we would like to do a simple demonstration. Please stare at the red cross in the center of the screen and be sure to concentrate on this red cross. Okay, now that we woke you guys up, here's a photo of a cute puppy to calm you down. Today, our presentation will be focusing on fear conditioning and PTSD. Hypothetically, if you had developed PTSD from our little demonstration, then you would no longer be able to handle the visual stimulus of a red cross or anything that reminds you of it, and you would probably be too traumatized to watch other video presentations, so we hope you are watching our presentation last.
With PTSD gaining notoriety as a debilitating mental illness, it is also garnering attention from many researchers worldwide who are attempting to ascertain a more concrete understanding of its neuropathology, symptoms, and potential treatments. The neuropathology of PTSD is complex, but it's gradually being uncovered by many talented and dedicated neuroscientists. While everyone presents symptoms of PTSD differently, there are several symptoms that are consistent across most patients. As for the treatments of PTSD, there are several treatments that have achieved clinically significant results. In our presentation, we will go over the neuropathology, the symptoms, and some of the treatments that have been deemed the most promising for PTSD. PTSD, or post-traumatic stress disorder, is an emotional illness and an anxiety disorder that can be triggered after a person or a loved one has experienced or witnessed a traumatic event, which can be classified as frightening, life-threatening, or just plain unsafe. The disorder became recognized as a formal diagnosis in 1980. But how do you know if you have PTSD or if you just have a normal anxious feeling that is triggered by a traumatic event? Well, most people who go through traumatic events may have temporary difficulty adjusting and coping, but with time and good self-care, they generally tend to recover. If the symptoms get worse, last for months or even years, and interferes with your day-to-day functioning or activities of daily living, you may have PTSD. So what exactly causes PTSD? It's hard to say for sure, but the recent research indicates that it's caused by a complex mix of several things. This includes stressful experiences, which includes the amount and severity of the trauma you've gone through in life, inherited mental health risks, such as a family history of anxiety and depression, your inherent personality, or temperament, and the way your brain regulates the chemicals and hormones your body releases in response to stress, such as cortisol. An event that is life-threatening, severely compromises the emotional well-being of an individual, or causes intense fear can lead to PTSD. A traumatic event can encompass a plethora of scenarios, such as experiencing or witnessing a severe accident or physical injury, exposure to war combat, enduring physical, sexual, emotional, or other forms of abuse, and even undergoing major surgery. Of course, these are just a few possible scenarios. Trauma is based on perception, so it's different for everybody. So what exactly puts someone at risk of developing PTSD? People of all ages can have post-traumatic stress disorder. However, some factors may make you more likely to develop PTSD after a traumatic event, such as experiencing intense or long-lasting trauma, having a job that increases your risk of being exposed to traumatic events, such as military personnel, first responder, doctors, nurses, etc., lacking a good support system of family and friends, and many more. PTSD symptoms can vary both in the onset and in the manifestation. The symptoms may start within 1 month of a traumatic event, but sometimes they don't appear until years after the event. They have the potential to cause significant problems in social or work situations and even in relationships. They can also interfere with your ability to go about normal daily tasks. PTSD symptoms are normally grouped into 4 types: intrusive memories, avoidance, negative changes in mood and thinking, and changes in physical and emotional reactions. Intrusive memories include things such as intrusive recall, flashbacks, intense psychological and physical distress when exposed to reminders of the trauma, as well as nightmares, dreams, sleep disturbance, insomnia, and uncontrollable thoughts. Avoidance includes things like feelings of detachment, isolation, estrangement, numbing the pain, lack of affect, depression, loss of interest in previously enjoyed activities, avoiding places and people that remind you of the traumatic event as well. Negative changes in thinking and mood include negative thoughts about yourself, other people, and the world, hopelessness for the future, memory problems, difficulty maintaining close relationships, and difficulty experiencing positive emotions. And the final one, changes in physical and emotional reactions include hyperarousal, anger, irritability, aggression, hostility, exaggerated startle response, impulsiveness, hypervigilance, always being on guard for danger, trouble concentrating, overwhelming guilt or shame, self-destructive behavior such as drinking too much or reckless behavior like driving too fast, depersonalization, derealization, stomach aches, headaches, muscle tension, and refusing to be alone. So having PTSD can also increase your risk of other mental health problems and life problems, such as depression and anxiety, which is fairly ironic because anxiety and depression put you at risk of PTSD. It's a vicious cycle. Eating disorders, suicidal thoughts and actions, social withdrawal, declining grades and academic failure, and engaging in other high risk and dangerous behaviors can also occur.
In order to describe the neuropathology of PTSD, let's start off by explaining the basic areas of the brain. The basic areas of the brain include the reptilian brain, the limbic system, and the neocortex. The reptilian brain maintains basic bodily functions such as heart rate, breathing, body temperature, and balance. The limbic system, this is an instinctive part of the brain. It deals with fear and pleasure. For example, when you pet a dog, it senses pleasure, and the dog wags its tail without thinking. The neocortex is the site of our higher level executive functions such as logic, imagination, planning, and control. This part of the brain allows us to make conscious decisions about the sensory information we have encountered. But since this part of the brain is conscious, it is also slower than the other parts. Now, the reptilian brain and the limbic system can be described as our primitive animal brain, and our neocortex can be described as our sophisticated human brain. Now, let's think about a soldier that experienced the trauma of war. How does this impact them? Well, their primitive animal instinct is wired up and ready to fight. This hyperactivity is optimal in a combat zone. But now let's take that soldier and bring him back to Canada. The neocortex, aka the intelligent human thinking brain, is able to recognize the geographical shift back to Canada. But where was this hyper-aroused area located? In the primitive animal brain, or otherwise known as the subcortical brain, particularly in a structure called the amygdala. The amygdala becomes hyperactivated and triggers a fight or flight response for any stimuli that may remind the veteran of the war he or she encountered. This automatic and on-edge reaction to every novel stimulus was very powerful and essential in a combat zone, but this hyperactivity can be debilitating outside the combat zone. Now, let's take a deeper look into the anatomy of the brain and really dissect our intelligent cortical brain as well as our instinctive animal brain. Key areas of the brain that are involved in fear and anxiety related to PTSD include the thalamus, the cortex, the amygdala, the locus coeruleus, the bed nucleus of the stria terminalis, the hypothalamus, and the hippocampus. First off, when one experiences a stimulus in our environment, the sensory information such as sight and sound are first processed in the thalamus, with the exception of smell, because smell bypasses the thalamus altogether and goes straight into the amygdala. This is why smell often evokes very powerful memories in patients with PTSD. Now, the thalamus can be thought of as a relay station that sends out the signal to both the intelligent cortex and the primitive animal brain, in particular the amygdala. Now, let's say a soldier goes out for a nice peaceful walk on July 1st, and then all of a sudden, boom! He hears a firework and he dives to the ground. Now, this reaction is caused by the primitive animal brain. In other words, he reacted without thinking. The signal from the fireworks is processed in the thalamus and sent to both brains. When the signal gets to the cortex is going to think about it and say, an explosion? It sounds like a bomb. Oh, wait a minute, but I'm in Canada. Oh, phew, it's just some fireworks for Canada Day. The cortex can figure this out. However, simultaneously, that signal went to the primitive animal brain, in particular, the amygdala, which becomes hyperactivated. For a soldier, it becomes hyperactivated, particularly for explosions, which in war meant a threatening bomb and possible death. During a traumatic event, people think that their life or the lives of others are in danger. They may feel afraid or feel that they have no control over what is happening.
Let's think of these two signals as roads. There is the expressway, suggesting that the response happens before you are consciously aware of the fear. Only after this fear response has been activated does the conscious mind kick in. The sensory information also takes something called a thoughtful route. This route is the long way which travels from the thalamus to the cortex. The cortex gives sights and sounds meaning, enabling you to be conscious of what you are seeing and hearing. The cortex decides whether the sensory information warrants a fear response, or in other words, if the fear is a genuine threat. The cortex is vital for turning off the anxiety response once the threat has passed or has been deemed a false alarm. But if the threat is genuine, the cortex tells the amygdala to continue being alert. Fear can be a good, useful response, essential for survival. In this situation, the bed nucleus of the stria terminals maintains that fear response, causing longer episodes of fear and anxiety. However, for individuals suffering from PTSD, these physiological changes may occur within the individual, even when they are not presently in danger. This anxiety or fear is felt because a certain stimulus they encountered can be associated with the fearful memory. The expressway travels immediately from the thalamus to the amygdala. The amygdala is the emotional core of the brain whose primary role is to trigger the fear response. Information passing through the amygdala is associated with an emotional significance. Any cues that come from your incoming senses that are associated with a threat in the amygdala, whether that threat is real or not, whether the threat is current or not, are immediately processed to trigger the fear response. This fear response then travels from the amygdala to the locus coeruleus. The locus coeruleus receives signals from the amygdala and initiates the classic anxiety response, such as rapid heartbeat, increased blood pressure, sweating, and pupil dilation. This signal is then sent to the hypothalamus and the pituitary glands, which activate the adrenal glands. The adrenal glands sit on top of your kidneys and have very specialized functions. The hormones of the adrenal glands are released after the sympathetic nervous system is stimulated, which occurs when your body encounters a threatening or stress-inducing situation. This can cause increased heart rate and blood pressure, skin conductivity, and hyperventilation. Once the sympathetic nervous system is activated, the fight or flight response is initiated by two important hormones that are secreted by the adrenal glands. These are epinephrine or adrenaline and norepinephrine or noradrenaline. The adrenal glands also produce cortisol and corticosterones to help you respond to stress and regulate blood pressure.
The adrenal glands create a mass production of glucocorticoid hormones, such as cortisol, during stressful situations. This increase in cortisol can have a significant effect on the hippocampus. Now, the hippocampus can be thought of as your memory center, storing raw information from all senses along with the emotional baggage attached to it by the amygdala. However, too much cortisol from the adrenal cortex can short-circuit the cells of the hippocampus, making it difficult to organize the memory of the trauma. Normally, the hippocampus's job is to file memories so one can retrieve them later, but in times of danger, it stops filing memories, which makes it harder for PTSD patients to recall the trauma later on. This is why memories frequently lose context and become fragmented. In a situation of high stress, your body enters survival mode, which means that all functions that are essential for survival are pushed into overdrive, while the functions that are not essential for survival are switched off. This is an evolutionary safety mechanism, which is fast and instinctive. It's our body's way of protecting us. Emotional memories are stuck in the limbic system, so a trigger can set off the alarm in the amygdala. A trigger could be a color, a smell, a sound, or a sensation. The amygdala is part of our primitive animal brain, and this part of the brain is reacting before we think, and releasing chemicals and hormones throughout the brain before we are fully conscious of the matter. So until we think back with our cortical brain and reflect, we sometimes ask ourselves, why did I do that? How can trauma and PTSD change our brains? Scientists have studied the effects of extreme stress and the physical and functional neural changes that accompany a traumatic event. During a trauma, a sudden and intense release of the stress hormone cortisol can overwhelm and negatively affect the cells and neurons in the hippocampus. For instance, youth who experience interpersonal trauma and display post-traumatic stress symptoms may develop cognitive deficits that impact their development. These children who have experienced extreme adversity demonstrate abnormal hippocampal dysfunction. In a popular study by Carrion, researchers observed the brains of children who have experienced a trauma and children who have not experienced a trauma during a memory processing task. The children who had post-traumatic stress symptoms demonstrated reduced activation of the right hippocampus during the memory task. Further, severity of symptoms of avoidance and numbing correlated with reduced left hippocampal activation during this task. Youth who experience child maltreatment and develop PTSD can also develop cognitive deficits that impact their academic, social, and emotional development. In addition, there is evidence of smaller hippocampal volume in adults who experienced childhood maltreatment and developed PTSD. In a longitudinal study by Carrion, Weems, and Rees, they found the hippocampal volume reductions to be associated with high levels of cortisol within the maltreatment-related PTSD group. Also, these children have extreme difficulties adjusting to a new environment. For a child that grows up in an abused environment, you can take them out of that home and put him or her somewhere else. But if he or she had experienced a significant amount of abuse in that home, That abuse has already impacted their arousal system in their primitive animal brain. For example, a child may become easily startled by the sound of a door opening. So, no matter how much they may want to overcome this in their intelligent cortical brain, they cannot change it by thinking any more than you can change your heartbeat or blood pressure.
One of the best studied functions of the amygdala is fear conditioning. This video is an example of fear conditioning.
Experiment 2. The food is connected to a mild electrical current. The hamster has learned a valuable lesson. Beware the hand of man. Wise guy, eh? Ow! 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 Oh. Bart, could you go get the cupcakes? Cupcakes, yes. Sweet cakes for all.
In a typical fear conditioning experiment, a mouse is given an unconditioned stimulus, which is inherently negative, such as a painful foot or tail shock. This unconditioned stimulus produces a natural unconditioned response, in this case the expression of fear. The experiment also uses a neutral stimulus such as a sound, which on its own produces no fear. But after a number of trials where the neutral and unconditioned stimulus are presented together, the animal learns the association between the sound and the shock. The neutral stimulus of the sound is then able to cause the fear behavior by itself without the shock.
The process of learning in this way is commonly known as classical conditioning. But how does this happen? Well, the unconditioned stimulus of the foot shock travels through the spinal cord to the thalamus and the cortex, which then project to the amygdala. The amygdala is composed of a number of different nuclei. We will be focusing on the lateral nucleus and the central medial nucleus. The lateral nucleus is the primary input nucleus of the amygdala, which receives information from the thalamus and the cortex, while the central medial nucleus is the primary output nucleus of the amygdala, which projects to a number of different structures within the brain. It projects to the hypothalamus, which activates the adrenal cortex and triggers the release of the stress hormone cortisol, as well as stimulating the autonomic nervous system. The synaptic inputs from the unconditioned stimulus of the foot shock were strong enough to excite the neurons within the lateral amygdala, which in turn results in the activation of the neurons in the central medial nucleus, which successfully produces a fear response. However, before the association between the neutral and unconditioned stimulus, the inputs from the neutral stimulus alone were not strong enough to activate the neurons within the lateral amygdala, so the central amygdala neurons remained unstimulated and no fear response was displayed. After a few trials, when association is completed, the neurons encoding the shock and the sound would start firing together. This process is known as synaptic plasticity. The neutral stimulus then becomes a conditioned stimulus and is able to produce the conditioned response of fear without the foot shock. Related to fear conditioning is the concept of fear extinction. Fear extinction occurs when the conditioned stimulus of the tone is presented repeatedly without the unconditioned stimulus of the foot shock. The animal then gradually learns that the sound no longer predicts a shock, and after a number of trials, the association is broken and the fear behavior is no longer displayed.
In an attempt to combat this Pavlovian conditioning, a variation of psychotherapy may be employed. Psychotherapy is aimed at changing a person's behavior to help them overcome problems and obstacles in order to improve their mental health. Psychotherapy is an umbrella term which encompasses several treatment variations such as cognitive behavioral therapy and cognitive processing therapy. Prolonged exposure therapy is a treatment in which patients are forced to confront a sound or image that has previously triggered their PTSD, while in a safe environment, of course. Examples of triggers can include fearful faces, a loud bang or pop, etc. Amit Etkin led a 2012 study in which PTSD patients were administered exposure therapy. Patients were instructed to view an image of a fearful face and pick out alternate details of the photo, thereby ignoring the emotional cues present in the photograph. Results showed significant improvement in patients whose amygdala was less activated and had higher activity in emotion-regulating areas in the prefrontal cortex. This is where transcranial magnetic stimulation comes into play. Dr. Etkin explained that the idea behind TMS involves strengthening these brain areas temporarily in order for them to respond better to treatments. One study found that 5 Hz administered to the left dorsolateral prefrontal cortex had a high correlation with improvement in PTSD symptoms. Furthermore, Cohen et al. Found that 10 Hz administered to the right dorsolateral prefrontal cortex also yielded significant results. The goal is to increase connectivity between the amygdala and the prefrontal cortex. However, future studies conducted in conjunction with pharmacotherapy and CBT or exposure therapy are needed before anything conclusive is drawn.